Yvette Kelly with the Managed Care Technical Assistance Center, and I'd like to welcome you to today's Infection Control for Residential Providers webinar. Today's webinar will be led by our state partners at the New York State Office of Mental Health. A few housekeeping items before we get started so you know how to best participate in today's presentation. Please note that the slides and recording from today's presentation will be made available and posted to our website. You will be able to access these materials on our website, mctech.org, within the next few days. We will also have time for questions at the end, so we are asking participants to please submit your questions at any point during the webinar. When submitting your questions, if you can please utilize the chat box feature, which is located on the right-hand side of your screen, to submit your questions. And when submitting, if you can please submit to all panelists using the drop-down menu, and that will just ensure your question is visible for all of us to see. And as the presentation concludes, our presenters will do the best to answer any questions that have come in the time permitted. For any technical difficulties, please chat to the host who should be able to assist you. And with that, I'm going to pass it over to Chris to kick us off. Thank you.
Good afternoon, everyone. This is Chris Smith. I'm the Deputy Director of the Adult Community Care Group at OMH. Some of you may know me from the New York City field office, but several months ago I shifted over to a central office role. So we're here today to give you an update on infection control procedures for residential providers. Dr. Flavio Casoy will walk you through both the ongoing precautions we've been working with for the last several months, and we'll also update you on the new microcluster designations and some enhanced precautions accompanying these. And we'll also talk about some of the recommendations we've developed for integrating telehealth in in-person care. But before we get started with that, I just want to take a minute to thank you all so much for all the hard work, all the time, effort, and heart you and your teams have put in to support the people we serve. We want you to know that we recognize that you've gone above and beyond and that we appreciate you and all that you do. So without further ado, I'll turn it over to Dr. Casoy.
All right. Thank you, Chris. Chris, Donna, thank you for all the work that you do at Central Office. I want to thank Yvette and Caitlin for helping us host this webinar. Most importantly, though, I want to thank you all, the participants, who are sort of running and keeping the residential programs going through this extremely difficult period. It's been 8 months, almost 9 months now that we've been in this COVID crisis, and you all have, because of all your work and all your efforts have saved literally hundreds of lives, keeping people healthy and going, and we're so thankful for all the work that you've done and all the effort, and we know that it's been extremely challenging. So we last presented a general infection control presentation like this in March. Since then, we've learned a lot of new information about COVID. So we wanted to give you this update and take an opportunity to hear your questions, try to answer them, and keep this dialogue going as we go into what will be a very difficult winter period. Next slide. And one more. Okay, so a lot of this information, most of you will already know. So just starting off with some review, and just to make sure that everyone is on the same page. COVID-19 is an illness caused by a respiratory virus. Symptoms appear 2 to 14 days after exposure. That's reassuring because we know there's a pretty clear window. For the most part, you don't see less than 2 days or more than 14 days. Most people who become symptomatic, you can get a pretty good sense of when they were exposed, which is good. It helps with planning and public health interventions. When there's a fever, fever is a common symptom. When there is a fever, we're counting it at temperatures of 100 degrees or greater. People can also experience the subjective feelings of a fever, the malaise, the fatigue, the achy muscles, the chills. all these things that, anyone here who's had a flu before has experienced. It's possible to have some of these subjective fever symptoms even without a high temperature. So these can happen independently. This is primarily a respiratory illness. So people can experience a sore throat or cough, shortness of breath in more severe presentations. People can have difficulty breathing or even have the oxygen level in their blood fall to more dangerous levels. Less common symptoms include a runny nose, a headache, gastrointestinal symptoms like nausea or vomiting or diarrhea. And then people also experience the famous loss of taste or smell that is so distressing to so many people. There are other symptoms as well, but these are the more common ones. Everyone experiences their own COVID differently. How is COVID-19 transmitted? So first and foremost, this is a respiratory illness, and it gets transmitted through the air. People produce droplets of spit when they sneeze or cough or yell or sing or laugh, play the trumpet, or even when they're talking. And these travel through the air and land on other people. And then that's how the infection gets transmitted. In enclosed or unventilated spaces like a car or an office, these activities can also lead to COVID-19 becoming aerosolized, where it's not just these little droplets that are flying through the air and landing on other people, but they actually get suspended in air and kind of saturate the space. And when this happens, people are at very high risk of becoming infected because the virus is just all over in the air. One thing that is very dangerous about this infection, about this illness, is that there's always an unknown percent of individuals who are sick and are transmitting the disease who show no symptoms and can infect their loved ones, their peers, their patients, their clients unintentionally. So this is one of the most tragic aspects of this illness, where you really need as many people as possible doing as much as possible to prevent transmission, even when they feel well, because any individual, when they feel well, could still be an asymptomatic transmitter. So that's really important. A secondary way that COVID is transmitted, less important but also preventable, is that the virus, quote unquote, survives temporarily on surfaces where an individual can touch that contaminated surface and then touch their mouth or nose and become infected that way. You cannot get COVID through your skin, but you do touch these surfaces, and then you touch your face, and that's how the transmission happens. That's why we say hand hygiene, super important. That's why we say stop touching your face, because these common behaviors, touching your face, grooming, and so forth, is something that can help transmit this virus and get you sick. So next slide, please. So let's talk about these droplets. And these are teeny tiny little drops. The smaller the droplet in which the virus survives, the more infectious the illness. Measles is one of the most infectious diseases that's out there, and it's so infectious because it survives in such teeny tiny little droplets. Ebola, on the other hand, a super deadly illness, much less infectious because it needs larger droplets to be transmitted. And when those come out of a person, gravity catches them, they fall to the ground, they don't travel as far. COVID is somewhere in between. That's why we say we strongly encourage, maintain a distance of 6 feet, because most of the droplets where COVID could travel will fall to the ground within those 6 feet and not be in the air anymore. Of course, in closed spaces, COVID can become aerosol. So how big are we talking here? If you look at your pinky finger there on your keyboard or on your phone, that's about 1 centimeter across. If you slice the width of your pinky finger in 10,000 equal slices, each of those little slices is about a micron across. The normal size droplet where COVID can live and travel through the air is 10 to 20 microns. So 10 to 20 of those teeny tiny little slices of your pinky finger. Droplets that are less than 5 microns can become aerosolized and just stay in the air. So these are microscopic. You can't see them, but they still travel and they can still infect you. So it's not just the drops that you see. The problem really are the drops that you don't see. This is why the masks are so very important. If just as a way to compare, if you pull out a hair from your head, the width of that hair follicle is about 125 to 150 microns. So these are really tiny. Next slide. Okay, so how do you prevent transmission? The goal here is to have as many people as possible adopt as many preventive behaviors as possible, because the more that you slow the transmission, the fewer the people will become infected and fewer the people will be going around transmitting this virus. So slowing the virus is super important and helps keep everyone safe. So most importantly is to wear a mask. What does the mask do is it puts a physical barrier between the back of your throat, where you are most likely to become infected or most likely to shed virus to infect others, and the world. So if you have a mask on and you cough or sneeze and you're an asymptomatic carrier, most of those droplets will be caught by the mask. If you're out and about and you happen to walk through a cloud of spit that someone just sneezed and you're wearing a mask, well, that mask is going to be a barrier between your throat and all those infectious little droplets. Super important to wear a mask. And you have to have it cover your nose and your mouth. If you look at this picture, the nose and the mouth connect at the back of the throat. So if you're just covering your nose or just covering your mouth, it's almost as if you're not wearing a mask, because air is still going out and air is still coming in, and that could still impact you. Of course, if you wear a mask that only covers your chin but leaves your mouth and nose exposed, that's an interesting fashion accessory, but it's not really doing you or anyone any good. You want to wear a mask whenever you see another individual. You want to be wearing that mask. You also want to maintain, as I said, 6 feet distance from all individuals. Why? Because in those 6 feet, most of those droplets will fall to the ground and no longer be in the air. So keep that 6 feet distance to keep you from getting those little droplets on you. You really want to reduce time with other people indoors, especially in poorly ventilated places, because it's in poorly ventilated places that aerosolization happens. So you want to keep your window cracked. You want to keep the door open. You want to do these things that help promote a breeze. I know it's cold, but a little bit of a chilly draft is better than letting all this virus getting aerosolized. To prevent contact transmission, rigorous hand hygiene, not touching your face, that helps reduce that risk. And almost as importantly as everything else, and more importantly than ever before, get the flu vaccine. If you get influenza, that is a huge risk factor for all sorts of worse outcomes if you also get COVID. So you can get both COVID and the flu vaccine. So COVID and the flu. So the flu vaccine will help reduce one of these big risk factors, for worse outcomes, like going to the hospital or having sort of a really serious illness or even dying from COVID. So getting the flu vaccine, keeping yourselves from getting the flu, not letting the flu transmit this winter will keep a lot of people safe or safer if they were to catch COVID-19 also. So super important. Tell your family, tell your staff, tell your clients. Make sure you yourselves get your flu vaccine this year. So infection control, we just posted on November 12th, I think, an update to the infection control manual. Super comprehensive guide on all sorts of different things that residential and ambulatory programs can do to keep their residents, their clients, and their staff safe. Really recommend everyone to review that. This PowerPoint takes on several points from that manual, but by no means not all of it. So it's much more comprehensive over there, so take a look. Other things to do is right away, educate your residents and your staff, remind them about physical distancing, wearing those masks, hand hygiene, not touching your face. These are simple things to do, but super effective and super important. On the manual, there's the link to the Department of Health website where they have really great posters that remind folks of what to do and when and how. Post them up around your facility, post them up around your house to remind yourselves and your teenage kids on what they should and shouldn't be doing. Make sure you disinfect daily. Frequently touched surfaces like tables and doorknobs and light switches, toilets, sinks, and things that people come in contact with all the time. Just wipe those down, disinfect them, get rid of that virus to reduce the risk that people are having contact transmission. Remind your residents and your staff to report symptoms right away and get themselves into quarantine or isolation. That'll help protect their peers, their friends, their loved ones from also getting sick. It's an act of kindness. It's an act of love to follow quarantine and isolation precautions. Change your physical plant around as much as you can. Move the furniture. Do things to promote physical distancing. Put tape on the ground if you have to. Every program has a different physical plant. Very hard to give advice that applies to everyone. So really be creative to make the easiest, most natural way for people to move around in the space to be in a way that's 6 feet distant from everyone else. And again, I can't say enough, get your flu vaccines. That will definitely save lives, especially if you have in your families folks who are elderly or folks who are pregnant. Get those flu vaccines. Make sure they get their flu vaccines too. Next slide. So this is a long slide. I cut and paste directly from the manual. I just want to give a sense of what kind of like the level of detail in the manual. This is talking about your staff who might become exposed or have a close contact with someone with a known or suspected COVID-19 illness. If these individuals have a close contact and your program is facing staffing shortages and you've exhausted other solutions, and that individual is essential for the functioning of your program, make sure that this gets reviewed with their supervisor, with your HR staff, and if this, once this happens and this is determined, these individuals can continue coming to work, provided that they're checking their temperatures twice a day and making sure that they're not getting a fever. They can use your home thermometer or your program's thermometer. They have to follow all the guidance around mask wearing and physical distancing very carefully. It's very important. And if they were to develop any symptoms, they have to go home right away and start the period of quarantine or isolation. But for programs that are facing staffing shortages, staff who have a close exposure can continue coming to work. Now, any staff who develop symptoms or who test positive, then they cannot. They have to go into isolation. And the manual goes into a lot of detail as to when staff can come back to work. So take a look at that, and happy to talk about that in the questions as well. Next slide. So just to introduce or remind folks of the new New York State microcluster strategy to notify communities of their level of risk in having community transmission of COVID. On this map, you see a yellow precautionary zone and orange warning zone. There's no red here. Hopefully there won't be red anywhere, but that's a possibility. You can use the New York Forward website to look up your programs, to look up your homes, to look up your kids' schools, to look up your grandparents' nursing homes, to see if any of those are in a particular micro zone, a micro cluster, and if so, how to think about in terms of taking extra precautions. Next slide. So, and we're using the definitions in the cluster strategy to help programs figure out when they should be taking enhanced precautions. So programs that are located in a red or orange zone, programs that have a cluster of 2 or more cases in their residents or their staff, programs that, receive the recommendation from their local health department or us at the Office of Mental Health to take extra precautions, really should implement sort of measures that will reduce the risk that their residents and clients can be exposed to the virus or transmit the virus to other people. And we'll get into some details about that in a little bit. The recommendation is that once the program goes into enhanced precautions, that they stay in that extra level of alertness for 2 weeks until the conditions are no longer met. And what this does is that it allows time for folks who are asymptomatic transmitters to sort of get out the window where they're infectious, and if there is still sort of spread that's happening quietly without people getting symptoms, in those 2 weeks, it'll be a pretty good chance that that'll come to light. So it'll help keep everyone safer. So we'll talk about what enhanced precautions are, but that's the definition. So red or orange zone, a microcluster, or a recommendation from the local health department or OMH. Speaking about staff, it's really important that all your staff wear a mask covering their nose and their mouth for the entire time that they're on shift. The only exception is if they are in their own private office with the door closed. Then they can take the mask off. But if the office is shared or if there's another person in the room, that mask has to stay on, even if the desks are 6 feet apart. It's not physical distancing or mask wearing. It's physical distancing and mask wearing. If you see another person, you're wearing a mask. That's really important to emphasize because you really want to keep a barrier between the back of your throat and the world at all times when there's other folks around, to protect yourself and to protect others. The Department of Health came out this weekend with the recommendation that all staff that interact with clients should also wear a face shield. But the DOH recognizes that it's very difficult for programs to access face shields and purchase it and find it. So programs that are able to access face shields for their staff, should do so. And what that does, it gives that little extra precaution between your eyes and the world, because a droplet landing in your eye can also transmit the virus. But if that's not possible, if the resources aren't there or the purchasing isn't there, double down on the mask, on the physical distancing, on the hand hygiene, and that will keep people safe. It's always masks plus physical distancing, always. If you can get a face shield in there, that's good. But if you can't, double down on what you can do. Next slide. Okay, so talking about testing. Folks have heard there's really 2 types of testing out there now. Well, 2 big families, really. One is a diagnostic test or a polymerase chain reaction or PCR test. And access to those can be found on the Department of Health website, and the link is there. These tests are the gold standard. When you get a positive or a negative result on these tests, you can be pretty certain that those are accurate. Of course, there's always the issue if someone doesn't get the sample correctly or doesn't use the right swab or whatnot, then you can have a problem. But for the most part, if the sample is obtained correctly, you're going to get a trustworthy result. The downside of these tests is that the results can take a day to a week to come back. And that's very difficult. That's a long time to make a decision. That's the downside. So these rapid tests are coming online and spreading to doctors' offices and pharmacies and urgent care centers. There's even some home tests that are being sold that are on the market now. These are less accurate than the PCR tests, but they give a result, in minutes to hours. So they can be acted on right away. So if you have a staff member who has a positive rapid test, they can go into quarantine. But if they get a confirmatory PCR test that's negative, then you can assume that the negative PCR test is more accurate than that false positive rapid test, for example. Or if you are in a place that a residential program that sadly is having a lot of cases, and the local health department comes in and says, okay, let's give everyone, all staff, all residents, a rapid test every 3 days. We're going to do this. The rapid test is a pretty good way to do a general screening, and is repeated often enough that can catch the spread of this virus. Any positive results, of course, should be confirmed with more accurate PCR, but these rapid tests are a pretty good way to do surveillance. More testing is everyone's friend, so we recommend that. One thing to think about for the programs, especially the programs working with young people, adolescents, going home for the holidays is something that people really want to do. So think about working with a local health department or a local provider in using tests, rapid tests or PCR tests, to help make decisions as to when that's appropriate. So if a young person is going home to a large family, maybe two grandparents, maybe get that young person tested before they go home, just to get that little bit extra certainty that they're not taking the virus to their family members' houses. When they're coming back, maybe once they're back in the program, get them tested again, just to see if they're bringing the virus back in the residential program, help protect the staff and the other kids. Something to think about. If folks are in high risk situations, elderly grandparents or whatnot, really think about instead of a home visit, maybe using like a virtual video visit. It's sad, people want to go home, but think about this clinically, the risk benefits of going home versus not going home, and think about what alternatives may be acceptable to the kid, to the family. This is a good time to do education for the family, for the child, and incorporate them in making the decision as to what's an acceptable level of risk. Ultimately, these are clinical decisions for the clinical team, but testing can be really helpful in getting some answers that you can act on. Next slide. Okay, let's go into some specific guidance for residential programs. So really double down on educating residents about COVID now. Everyone is tired. I'm tired of COVID. I'm tired of wearing a mask. Haven't seen my parents or my in-laws in 9 months. Everyone is ready to be done with this, but now we're going into a pretty difficult period. So remind everyone that there's light in the end of the tunnel, but we're not there yet, and double down on the preventive techniques. Be the cheerleader. Some residential programs offer group therapy or psychosocial rehab groups or of different kinds. If your program offers indoor groups, make sure that there's no more than 10 people in the room, including leaders and participants, right? So no more than 10 people. All these individuals should be able to be 6 feet away from each other. The room should be well ventilated, lots of outside air coming in, or inside air going outside so that there's fresh air being circulated through. Everyone should be wearing a mask correctly. If folks aren't wearing a mask or they don't want to wear a mask, They either shouldn't be in the group or the group shouldn't happen. If the room does not fit 10 people, then you got to reduce the size of the group. So make sure that everyone can stay 6 feet away from each other. And then indoor groups should not last more than an hour. So no more than 60 minutes. Keep it short, and then let there be circulation, ventilation in between groups, so people aren't breathing each other there. Programs that do outings, recreational or other types of outings, make sure you only go to places that are well ventilated, places where distancing can be maintained, places where hand hygiene can be maintained, preferably places that you can walk to so you don't spend a lot of time in small enclosed vehicles where COVID can be aerosolized. So that's something to consider, how to get to and what are the conditions there. Next slide. We encourage programs to continue to accept new residents. If folks need a place to live, a transitional place to go as they get back on their feet. But all programs are absolutely encouraged to request and require an attestation from the referring facility that the resident who's being referred doesn't have any new COVID-19 symptoms. If the referral is coming from a hospital, whether a medical hospital or a psychiatric hospital, the program can require a negative test within 72 hours for that resident to come. But if the referral source is not a hospital, then don't require the test because other referral sources might not be able to access that test. So yes, from a hospital, but not from other referral sources in the community. Now, the exception for the hospital is if someone is hospitalized for COVID and has completed their isolation period, that is, they've gone 14 days since the test or the symptoms first started, their symptoms are much improved, no fever within 72 hours, they don't have to repeat that PCR test because it's likely that little dead pieces of the viral RNA will still get picked up because this is a very sensitive test. And people can stay positive on the test long after they've improved from the illness. So if someone has a documented positive test, they've gone through the isolation or quarantine period, they're better, that's enough. You don't need another negative test because most likely the test is not going to be negative for a long, long time. But these individuals are no longer infectious, so they can come. When someone comes into a new residence, a new client, it is preferable, if possible, though we know it's not possible for many, many programs, for that resident to have their own room, to pretty much always wear a mask for at least the first 14 days, and be reminded about physical distancing and so forth. Lots of education during this time is really important. And they should be encouraged to stay in their room as much as possible. Until they've been there for that period when symptoms can emerge if they are sick. It's a way for them to keep everyone else safe. So that's highly encouraged. Now, after that period, right, these folks are living together. So in a way, they're within their own bubble. So staff always should wear a mask. But if there isn't any new residents for a while and folks are staying, pretty good about keeping themselves isolated from others, there is a place for residents, to be less careful around each other, just the way we are with our families at home. When I'm at home with my family, I'm not wearing a mask while I'm around them. Only when I'm around people who, I don't live with, who are not in my bubble. Of course, staff are coming in and out, so the bubble is always broken. So we encourage, residents to wear the mask, especially around staff. But we do understand that residents are not going to want to wear a mask all the time when they're in their own home. So it's a balancing act, and you've got to talk to folks. Okay, next slide. Okay, so if a resident develops symptoms, well, at that point, we really want everyone in the facility to be wearing masks, hand hygiene, do all the things that you got to do really intensely. The individual who has symptoms, really encourage them to stay in their room. Ideally, they're in a single room. If they had a roommate, ideally, if possible, though we know this is difficult, that roommate should also have their own room if possible. If the roommate after 14 days is still symptom-free, they can share a room with someone else. The resident who's showing symptoms or who tests positive should take meals in their room, and everyone should be wearing a mask at that point. Programs should immediately contact their local health department, to initiate contact tracing, for help with testing, and the local health department may ask the resident staff for help with internal contact tracing, figuring out who internal to the program may have come into contact with that individual. Contact your field office so that we know and we can help out. Most cases will not need a hospitalization, but some might. So, you might need to call 911 or transport the person to the hospital. Just give the hospital a heads up that there's someone with likely COVID coming their way so that they're ready to receive them. If you have more than one person who's positive or who's showing symptoms, they can share a room, especially if space is tight. This will help isolate, this will help contain the virus just to those individuals. Talk to the clinic, talk to the providers about getting nicotine replacement therapy so that they're as comfortable as possible and not walking back and forth to smoke cigarettes. Next slide. Really encourage your more vulnerable residents, those who are older, who have medical problems or who smoke, to be, super safe, like focus education on them, increase the hygiene of the frequent contact surfaces even more, 3 times a day. If you have several bathrooms, facilities, set one aside for people with symptoms or who test positive. Make sure you're wiping down the surfaces after each use. Encourage people who are not positive or who are not symptomatic to use a different bathroom so that one is specifically for folks who are having symptoms or who've tested positive. If you only have one bathroom, it's super critical to disinfect surfaces between uses. Leave the windows open, leave the fans on. Make sure that all the steam is cleared out between uses, between showers. Make sure that you encourage people to use masks in the bathroom, unless, of course, they're showering, and try to stagger shower times. Leave the fans running for at least 20 minutes between showers. Just try to clear that air as much as possible. And encourage the folks who do have symptoms or who test positive not to use shared spaces. It's okay for them to go outside, but probably not the living room or the common rooms as a way to keep everyone else safe. Okay, next slide. So, our folks, our residents, do get hospitalized from time to time, either medically or psychiatric. Sometimes folks go to the hospital because of COVID. They might come back with some symptoms. The way to know as to when isolation or quarantine can be discontinued is 14 days past since the first symptoms began. The symptoms have improved, and it's been at least 72 hours since the person has had a fever or needed fever-reducing medication. So fever-free for 3 days, 14 days since the first symptoms began, and a big improvement in the symptoms. If the person is still very sick at day 17, they're still in isolation, still in quarantine. It's whichever one is longer. If the person still has fever at 18 days or 20 days, they still need to be in isolation. Make sure that you talk with staff and residents about fears about COVID transmission. People will need a lot of support, especially when they come back from the hospital. And folks who are coming back from the hospital, even if it's not for COVID or, if it's for a psychiatric condition or whatnot, treat them as a new resident and ask them to stay in the room as much as possible, just to be safe. Next slide. So for scattered site housing programs, so educate your clients about to avoid socializing indoors, especially about bringing visitors home. We would encourage them not to have visitors at home. So educate them about that. Remind them about hand hygiene practices. Remind them not to touch their face. Educate them about basic disinfecting of surfaces and about the importance of keeping distancing in public. On a case-by-case basis, make a decision whether or not to continue in-person visits to these clients. Some clients are going to be okay with telephonic or video visits. Other clients, especially those who are more fragile or more vulnerable, who need help with medication or food or basic supplies, or who are at risk of disengaging from care or might be at risk of having to go back to the hospital, those probably still need in-person visits. For the staff who go visit them, make sure they're wearing the mask, maintain 6 feet distance in the visits, and hand hygiene before they go in the apartment and after they leave the apartment. Use that 60% alcohol gel to reduce the risk of transmission. Okay, next slide. So just talking about enhanced precautions, and this is the last slide. So for those programs that implement that are in the red or the orange zone or have a cluster, in addition to all the things that I've mentioned just now, cancel your indoor groups. It's really not worth the risk. If you're in a place with more community spread, with more people carrying the virus, just those indoor groups are not worth the risk. If you have hardy souls who like the cold, you are welcome to continue outdoor groups, but just don't do them indoors. We'd also recommend for you to suspend recreational outings. It will help reduce the exposure of your folks to the world and of the world to your folks, especially if you're in a place with more community spread. The Department of Health issued a guidance that all visitation should be suspended in residential programs that are located in red or orange zones, except when medically or clinically necessary, when it's for sort of meeting with a lawyer or a legal representative, or if someone has intellectual or developmental problems or cognitive impairments, that it's for their essential companions. This is most likely not our clients for the most part, but some programs, might have individuals with dementia or developmental delay, and they may have essential companions that it would be very difficult for those individuals not to have come visit. So this guidance from the Department of Health, applies to licensed residential programs, to the standalone Article 31 hospitals, to the crisis residences, and the residential treatment facilities. So these are the congregate OMH operated or regulated sites. And if you're in a zone that's red or orange, or you have a cluster, definitely work with your local health department or local provider to think about how to get testing for your clients, just to maintain a surveillance. Individuals who have symptoms, especially just to make sure that it is COVID, and so you can take the appropriate precautions. And these are the times that if you do have the face shields or the goggles available for your staff, this is the time to implement them, just for that extra protection. there's more virus around, more risky droplets. If that's not an option, really work with your staff, make sure they're wearing those masks correctly, hand hygiene, physical distancing. Double down on what's available if the face shield or goggles are not available. Okay, so that's the last slide. Let me turn it back over to Yvette to oversee the questions.
Yes, thank you, Dr. Kasoy. Before we move into the Q&A portion, I just want to remind folks that the slides and recording from today's presentation will be made available and posted to our website, mctech.org, within the next couple of days. So if you'd like to refer back to the material, you will be able to do so. We did receive a few questions that came in, and so one of the first questions are, do ceiling fans help reduce aerosols?
Well, what you want is circulation with the air outside. So if you have an enclosed space and you have that air sort of churning, without new air coming in, then no. So it's about ventilation with fresh air coming in that room or that car or whatnot. So you don't want to be in a small space, even if you have that same air circulating. It's not exchanging the air.
Thank you. There's a question, a point of clarity regarding wearing face shields, and so the question is, should staff wear face shields in addition to a mask, regardless of 6 feet distancing, or only if they are in a position where they must break social distancing to provide necessary services?
So always wear a mask. If the agency has the ability to provide the face shield, wear that as well. And we would strongly encourage, to maintain that 6 feet distancing, as often as possible. So to the degree that you can, do all three. If the face shield is not an option, do the distancing in the mask. If the distancing is not an option because you have to help, a client with an activity of daily living or something like that, it's better to have that face shield also. So, as much as possible, all of the above. But for sure, everyone should be wearing a mask.
Thank you. Susan, we had a number of questions come in related to the new CDC guidelines in terms of the 14-day quarantine period after exposure. They've been updated, and now they're recommending a 7-day quarantine if one has a negative test result, or 10-day quarantine without a negative test. And so the question that a couple providers have asked is, the OMH guidance still reflects the 14 days, and so they're wondering which guidance they really should be referring to.
So the Office of Mental Health, OASIS, and the Department of Health, and all the O agencies are aligned. So we're following the lead of our State Department of Health on this guidance, and so far this is what they're recommending. So this is what we're recommending too. So, and this is aligned with kind of all the other sort of facilities in the state. So we recommend that you follow kind of as we've written, because that's been vetted by our State Department of Health. We recognize that the CDC and the State Department of Health, are not on the same page on this, and that it causes a lot of confusion, but we're aligned with our State Department of Health.
Thank you. There's a question around whether or not an individual can get COVID more than once, and whether that would be with or without symptoms. I guess that would depend. But the question is, can an individual get reinfected with COVID?
Well, so this is like the cutting edge of the science. There's case reports that have come out that have talked about a reinfection, but those are controversial, and it's difficult to know whether the person just never recovered or if it's a new infection. For the most part, the belief is that once you've had it, you have some degree of protection for a period of time. Hard to know what period of time and when that immunity sort of goes away, if it goes away. And it's probably going to be different for different people. We just don't know enough. So it's possible, I guess I'll say. What we want to emphasize is even if you've had COVID before, you should still be following all the guidance about sort of hand hygiene and wearing a mask and distancing, because we don't know to what degree a previous infection protects you from future infections.
Thank you. There's a question from providers regarding the rationale for not allowing a negative test within 72 hours from other than inpatient referrals. And so the question is basically why just inpatient and why not other referral sources? Would we not require that? Yeah,
hospitals have ready access to testing in a way that community agencies might not. So we allow programs to require the negative test from a hospital, but this may be an unsurmountable barrier for some other referral sources, and we don't want to sort of close off opportunities to particular clients. If the residential program has a relationship with a provider or a local health department, they can get that individual tested once they arrive. But this might be very difficult to do, and we recognize that, and we don't want to deprive these individuals from from the care that they might need.
Thank you. There's a question around the enhanced precautions currently presented on slide 20. Should these be implemented regardless of microcluster designation or in the event that the facility location is designated as in the orange or the red?
That's a great question. These are precautions. These are extra precautions to be taken in case the facility is in a red or orange zone. If they have 2 or more positives in the program in that period of time, or if the local health department says take extra precautions, then programs should do these. Programs that are not in any of these situations can just follow the standard precautions that were described in slides 1 through 19.
All right. And what should providers do when residents refuse to wear a mask? What solutions would you give for providers in that case?
Well, that's the $1 million question, right? It's a lot of our society, inside and outside mental health treatment, systems, are refusing to wear a mask or follow basic public health precautions. I think you got to work with people where they are, figure out why it is that they're not wearing the mask or doing the appropriate, and precautions. Is it political? Is it personality driven? Is that they don't believe that COVID exists? And work with them where they are. I mean, it's we have experience in working with folks who have antisocial or anti-plan behaviors, or who do things that lead to themselves getting hurt. And I think we should see it in the same way. Everyone else around them should really double down on the precautions, right? So, when they're around, all the other residents probably be wearing a mask. The staff definitely have to be careful, encourage physical distancing, especially from them, by everyone else. It's a societal problem that transcends the mental health system, and we've seen a lot of resistance, right? We've seen resistance from every level of society, from the most vulnerable and marginalized folks all the way up to the most powerful and richest people who just don't want to do this. What can you do? The best we can.
And just being mindful of time, I think we have time for one more question. And there's a question around how providers, and I know you spoke about this earlier in the presentation, but how should providers manage home visits for weekends and holidays? And I think this is from an RTF provider. So what's your thought around how they should be able to, manage those visits?
Well, I think it's on a case-by-case basis and making a clinical determination. I mean, if the risk of infection is higher, for that particular family, then I would encourage the program to use telehealth or video platforms for that. It's very sad, and there's no good here. It's just the least worst. But I think it's very difficult, and I think it requires a lot of education, and it's going to be on a case-by-case basis, thinking clinically. Risk benefit of visiting, not visiting, infection risk, mental health needs, developmental needs, the family's ability to implement safety precautions. And I think it's there's no easy way to answer this. It's just like we're telling people, don't see your family for Thanksgiving, don't travel for Christmas, and people really want to, and it's hard. It's really hard. Yeah.
Well, thank you. So I think we are running short on time, so I do just want to thank everyone for joining us today, and just to remind folks to please visit our website, mctech.org, within the next couple days to access the slides and recording. I'd like to say thank you to our presenters, and we have a number of questions that you guys have asked today that we will send over to the state for them to review. And so just thank you. We were able to get to some of them, not all of them. And with that is going to conclude our webinar for today. And I'm going to say that you stay well and have a great rest of your day. Thank you so much.
Thank you, everyone.